Hi, my name is Madu. I'm here to make a presentation on comprehensive psychiatric evaluation for my patient here, Ms. NE, a 29-year-old African American female who presented for therapy following a recent repeated emotional outburst with her parents and other people. She just came in with a chief complaint, oh, nobody cares about me. They talk about me and I lose my temper. So on the time of discussion, this patient has reported long-standing emotional instability has been going on for over a year, increasing frustration towards others. She described the feeling of abandoned by her parents at the age of 10 to her grandmother. She was raised primarily by her grandmother. She reported feeling unsupported and often misunderstood. This patient also, we noticed that this patient mother has a history of alcohol. From what she told us on the time of discussion, she told me that her mother has a history of alcohol abuse, and she may be suffering from a mood disorder and intermittent explosive disorder, as indicated by her the mother trying to choke her. The family they have a very dysfunctional family. They don't, economic wise, they are not so buoyant, so they cannot. They don't have the money to look for psychiatric. To pay for psychiatric checkup, so there's no current history in the family about mental health. Even she has no history of mental health, and this is her first time of coming out for mental health examination. So objective wise, the patient is so alert and oriented times 4. She dressed so appropriately and then maintain adequate hygiene. She looks nice. So her posture was so tense and her affect was constricted. Her eye contact, she did not maintain continuous. She tried to occasionally avoid direct eye contact. She denied headache, no psychomotor agitation, no muscular or joint pain. She maintained a stable ambulation, and she denied any enlargement of the node, any splenotomia, history of splenotomia, no polydipsia, no polyuria, no neurological effect. She looks at her age. She looks healthy at her age. There's no medication. She's not on any medication, not medical or psychiatric. She's not on any medication. So the mental status examination, the patient look well groomed, has maintained a tense posture. Her mood, she's so tired and fed up. Her affect so constricted and congruent. Her thought process is goal directed, mildly rigid, but she has a trust issue about people. She has no delusion, no hallucination, no sign of suicide or homicidal or psychotic psychosis identified. She has limited insights because she struggles to recognize personal roles in conflict. She always finds herself being cheated, or she has never seen herself being at fault in any conflict. Her judgment is impaired in her interpersonal interpretation. Also, she has an intact memory. She's so defensive most times, trying to defend any action. Communication wise, she's not. She builds a block and she wants to defend every decision. So there's no indication of drug use or desire to use drugs. Differential diagnosis are, I see disruptive mood dysregulation disorder, DMDD. F34.81 is the primary diagnosis. The patient met this DSM-5 treatment criteria because she has severe recurrent temper outbursts, mood irritability, and emotional dysregulation present for over a year in multiple settings. So secondly is intermittent explosive disorder, F63.81. The third is dependent personality disorder, codependent feature, 60.7. My reflection on this patient is that something I would like to do different about this patient in the future. I would like to introduce trauma-informed care screening to assess her early upbringing, early childhood experiences, potentially to identify if she has PTSD threat at the early stage. Also, in the future, as a nurse practitioner, I will try to promote trauma-informed community resources, try to make sure I direct people to resources easily, and also educate my patient on healthy relationship boundaries, communication, the importance of good communication, effective communication in everything. So on this case, the primary diagnosis is DMDD. I will say that DBT is the chosen therapy for this patient because research has shown that DBT is successful in addressing emotional dysregulation, impulsiveness, and relationship dysfunction, which are central, which are mainly focus of this our patient. So key of intervention, I will try to do mindful training on this patient to build awareness of it, to know emotion, what triggers her emotion, how to handle it. Then distress tolerance skill to replace reactive behaviors, interpersonal effectiveness models to improve conflict resolution, also cognitive restructuring to change the negative self-belief that nobody cares about her. So on the impact of social determinants, she comes from a very poor family, very low income family, the dysfunctional family, fragmented, so she lacks support. So abandonment, she may not have enough money to go for mental checkup. So I'll try to strengthen her social connections to make sure she's connected so well and have a key recovering on this. And also on health promotion, I encourage my patient to do daily journal on daily activities, how her emotion, the reflection, the trigger, promotion, how well she did and how she handled it. It will help her to take control of herself, taking a daily record of how she went or how she handled her crisis will also help to improve her. So in conclusion, this case is highlights the importance of accurate diagnosis. To have accurate diagnosis for patient is very good. Then it will help you to help the correct psychotherapy for the patient, and also psychotherapeutic therapeutic education is also good because most of the patients are not well educated on mental health. So the strategy is to promote emotional regulation, resilience, and reconnection to her values. With all these things, I believe this patient is on a track on which she's really recovering. She's from the first time she walked into the therapy, now she is getting better. Thank you very much. God bless you.